Hey everyone, I'm Dr. Rob Assibey, Associate Program Director at San Joaquin General Hospital Family Medicine Residency Program, and new Physician Director here at California Academy of Family Physicians. And we know that addiction medicine is family medicine. Did you know that only 1 in 5 people with opioid use disorder receive treatment? We'd like to change those odds. In our latest series, we bring you stories of doctors and their patients who have worked together to reduce the harm done by opioid use disorder. These brief stories will bring you into the hearts and the minds of our guests. We hope that this will inspire you to do everything in your power to bring medical attention to the opioid use disorder patients in your practice. Hey again, Tipu. I'm excited to get into the second episode of our series, 1 in 5, Increasing the Odds for OUD Patients, with your interview with the legendary Dr. Marc Lasher.
Hey, Rob. A lot of us who work in opiate use disorder realm have heard about Dr. Lasher and the amazing work he does out of a bus. But I'm not sure how many other family physicians do. And if you don't, you really need to listen to this episode. He's an incredibly inventive and caring family physician who really took this old school bus and basically transformed it into a mobile clinic where he's driving around doing harm reduction, prescribing medications for opiate use disorder. I mean, it's just an amazing, amazing story and really motivational. So if you don't know who Dr. Lasher is or the amazing work he's done up there, tune in and listen on.
I agree. If there's not a more perfect example for when you take matters into your own hands, take that first step and others will join you. What Dr. Lasher has done in his career has been at the forefront of what we're trying to do. And it really highlights that if you're the first one to do it, other people will join you too.
I love how we can really feel how Dr. Lasher honors each and every patient and meeting them where they're at. And it's really funny because we use that term meeting someone where they're at all the time in addiction medicine, but we don't think about where it came from. And this is really where it comes from. Being the physician out there who's on the ground, getting your feet wet and meeting patients in their community where they're at when they're ready. And that's what Dr. Lasher does is he respects them and provides dignified medical care to his community where they're at.
What a legend we have for our listeners today, Tipu. You are all in for a real treat. I don't want to waste any more time, so let's get into this interview. Thanks, Tipu. Appreciate you.
Thanks, Rob. Let's hop on the bus. Hi, so I'm Tipu Khan. I'm a family physician and an addiction specialist. And I have the pleasure today of chatting with Marc Lasher, who's a physician out in Fresno and has been doing some pretty amazing cutting edge work for years now. Before OUD was widely recognized as a diagnosis, and before even medications for opiate use disorder were widely recognized as a treatment, Marc's been out there on the streets treating these patients and doing some groundbreaking treatment out there on his own and kind of paving the path. So I'd love to hear more about your background, Marc, and some of the great work you've been doing out there, if you could fill me in.
Thank you for having me. First of all, I'm a family practice doctor, and I did 2 years of my residency at UCSF here in Fresno and have stayed in Fresno. I've been in Fresno for the last 52 years. And the basic introduction was I live close to downtown in Fresno, and in the alleys, when I take out my garbage, we'd see a lot of needles. In the house that was abandoned across the street, there was lots of needles still in the building, and a neighbor and I would board up the house every so often. But seeing all these needles and knowing that they were being reused really bothered me. And I understand that what we do in sanitation, whether it's garbage or water or sewage, that saves a lot more lives than our very fancy heart and brain surgeries. So it made a lot of sense to me that there should be a way that these needles can get disposed of and also people can get clean, sterile needles. And so I took off one night of studies when I was in medical school down at that time it was called COM, College of Osteopathic Medicine, now called Western University. And I went to East LA and saw their needle exchange in action one night, and I was impressed. Right there on the edge of the street at the curb, there was a Jeep that had a biohazard container. There was a couple of other containers in which people got their paraphernalia, cottons, cooker caps, condoms, things to reduce harm. And I would watch police cars go by with their windows down, looking over and seeing what was going on, and it seemed like everything was pretty okay to them. And so when I got back to Fresno later on, I heard someone speaking about needle exchange. And I told them that when I become a full-fledged doctor, I'd be more than glad to help and provide medical care to those who are needing it in the exchange. And at that time, the needle exchange was doing home deliveries. And it was a pretty small operation, but after a while, it became too expensive for them to do that and too much time. And so they established a site. In residency, in my intern year, it's family practice and community medicine. All of us were needed to do a community project, and I knew I wanted to provide medical care at the needle exchange. And my faculty was very in favor of it, and they would supervise me. They would come out and co-sign the prescriptions I would write until I eventually got my full license after the intern year. It's from that constantly being out there, I got to see the needs of folks. And here we were in the middle of a park on a bamboo mat and the back of a car, and needles are being exchanged and medical histories were being done. And I was referring people to the clinic that I was working in. But then it became obvious we needed to start providing medicine right then and there. There was a very strong need, and did a small survey, and it showed that there were a lot of barriers to people accessing medical care, whether it was the stigma in the emergency room. I remember when I was an intern, folks coming in there that had an opiate use disorder, they were called GOMERs, an acronym for Get 'em Out of My ER. And our patients picked up the attitude and would do everything in the world to not have to go to the emergency room. And this is a highest level trauma ER from Sacramento to LA. And so it became real obvious that folks had a lot of needs. And as I've been out there, those needs became more and more obvious. And so it sort of feels like being out in Sherwood Forest. All of us that have some skills contribute to the well-being of our community. And that's basically what it is. I'm having to deal with the sheriff of Nottingham to a lot of systemic issues. And then there was an event that happened. One of my elderly patients, 86-year-old woman, she got to pass away during the night. And I was with her and her family through that event, through the phone, and we gave reassurances. And she passed away, and a day or two later, the adult family members came in to the office, and I was, oh, geez, like they're going to give me hell for not taking care of her so well or something like that. And instead, attached to the chart was a check for $2,000. And I looked at that, and I told them, you just bought us a bus. And so we moved from a bamboo mat in the park to a bus where people could come in. We could see discrete areas. We could treat abscesses, and we do a lot of abscesses until recently. The needle exchange would be outside of the bus, and inside the bus, people would access medical care. Instead of referring people to the clinic where I was doing my clinical work in residency, we started actually treating people right out there, writing prescriptions. And when my attending would come and co-sign my prescriptions, people would get medicines. And then finally, I would bring actually samples out with me from the clinic, and that seemed to work really well. But then in time, what happened was, still in the bus, I saw an article of a needle exchange in Vermont actually doing low barrier treatment. And I was fascinated. The fascination was, why didn't we think of that earlier? Why didn't we take that next step to actually, for those people who are interested in stopping their use, those people who I would approach when we were taking care of abscesses or bad infections, I would ask them, well, have you had enough? Are you interested in stopping? If you are, then we could actually start you on medication, start you on buprenorphine, Suboxone. And we had a few takers. And so we kept on doing that. I would send them to my private practice with instructions that you needed to be 12 to 24 hours with no opiate. Our needle exchange was on Saturday, so no opiates after using first thing Sunday morning, and then on Monday show up to the office. And it went well. It was really neat. Eventually it became a little bit more. But the big step was when we decided, okay, let's really do this and really offer it to everybody at the needle exchange who's interested.
Mark, wow, that's a lot of great information. And you have been doing some just absolutely groundbreaking and amazing work out there for years before any of us have. So thank you for all that wonderful work you've done. One of the themes I'm really getting from your conversation is how you've been able to create a very low barrier buprenorphine access program, essentially getting Suboxone into the hands of patients who need it when they need it. Can you give me some tips that you'd want to share with family physicians that are out there listening in that are trying to figure out how do I start writing that first prescription for Suboxone in my clinic?
Obviously, the person has to want to stop using. That's the most crucial part. It isn't that their family members or for whatever reason, it's their desire. And if they're truly interested, then that's the biggest hurdle. So if you have some type of way to notify people, okay, you could get started, you could be free of your opiate slavery for all practical purposes. People are sick and tired of it. And I use treating abscesses or cellulitis to have the conversation. Well, you want to continue doing this or are you interested in stopping? So the next step, if they are interested, is, okay, we'll go through some instructions. The basic one, and this is the beauty of low barrier treatment, will give you a prescription, you have the prescription, and that you wait for the short-acting opiates, heroin, Percocets, oxycodone, Narcos, all of those, you wait 12 to 24 hours as one condition. The second condition is that you have to have moderate to severe withdrawals. And once you meet those two conditions, the patient has the prescription, has it filled already, they have it at home, and I say, just before you would go and use, and you feel really bad, you know you don't have to use. So therefore, you start. And it's really simple, assuming that they're using a substantial use of opiates and not just 3 or 4 Narcos. I would have them start with a film of buprenorphine/naloxone. The brand name is called Suboxone. 8/2 milligrams, and I tell them, take a half of that to start, wait an hour, and then if you're still having withdrawals or cravings, take another one, and you could do that in the first day. I do up to 2 full films. Sometimes if someone has a really strong habit, I would even encourage them to go up to 3 films, but I try to do 2 just to make sure that we're not overshooting. And then on the second day, the next morning, they take whatever held them. So if 1 film held them or 1.5 films held them, meaning that no withdrawals or cravings, then they start with that amount. If that didn't hold them, they're to take the 2 film, and then if still having withdrawals in an hour, then take another half, and then wait at least another hour. And if still having withdrawals later on down the road, anytime that day, then take the other half. Maximum 3 film. And so I give them a week's supply until we touch base again. And then at that next appointment to see, did the 3 film or less hold them? If it doesn't, then basically going up 4 milligrams, which is a half of a film each time. It seems ever since fentanyl has come around, I need to give more than that. I need to go to 4 film. On very rare occasions would I ever go up to 5 film, but with a lot of hesitations and a lot of conversation with the patient.
So what I'm hearing is that you have a general concept of how you want to train patients to use their buprenorphine product. But given that the drug market varies and now fentanyl is changing how we're managing OUD, you're giving some flexibility there to patients to kind of decide what dose to work up to and how to take it. And I'll just use that as an opportunity to remind all of our listeners that if you go to familydocs.org/SUD, which is our website, you can hop on there and ask to find a MOUD champion. And that's peer support for physicians that are new to MOUD. And we have champions out there like Dr. Lasher that can hop on there and give you some advice on that first prescription you write. So just a plug to remember that resource. Mark, let me ask you to focus that a little bit more, if I could. I'd love to hear more about the bus. What all are you doing with the bus? Are you doing some primary care out there as well? Because as family physicians treating addiction disorders, a lot of what we do is going to be other stuff. Like you said, treating abscesses, depression, anxiety, etc. How much of your practice out in the bus is also just good primary care and family medicine?
A lot of people coming to the needle exchange, they avoid going to the doctor, they avoid going to emergency room until they actually are in such bad pain or their condition's so bad that they actually break down and go to emergency room. So we get to see a lot of things that normally are taken care of in family practice, but these people are not real compliant with going to their family doctor. Maybe because of the stigma that they perceive more so than what's actually there. So we'll get to see a lot of, obviously, abscesses, cellulitis, but then people have been out of their psych meds for a while, out of their diabetic meds, and it's just bringing them back up to where they were and encourage them to get back into their primary care provider and staying on top of it. There's a lot of that repeated conversation with the same person to get them back in. There's not a lot of people in their world that their interest is not past their drug use. And so all their colleagues, basically, they're getting help from other people who are using and maybe sharing and things like that. We were the last stop before they fell off the edge of the world. And we wanted to provide them as much help that we can, and also caring and saying, hey, we care about what you're doing. We want you to be safe. We want you in time when you're ready to stop. We'll assist you on that. But right now, let's get you as safe as possible. Let's get you well so that you don't suffer the complications of all your chronic issues like losing eyesight or losing a limb or suffering a stroke. We do a lot of treating of people at the needle exchange for their chronic medical issues. You keep mentioning our bus, and I have such a tremendous affection for our bus. The beauty of the bus was that, again, it was $2,000, an old broken down old bus. I have a friend, he would buy these and sell them to other people and things like that, and he gave us a great deal. So most probably we would have had to spend $4,500, but hey, $2,000. We got a bus. It was rolling. We had a confined space, and it was a safe place. People saw the bus as another safe place. We've been doing this for quite a while. In time, the bus died.
Oh, no, that's too bad.
It was a 1963 Crown bus, the rounded ones. It was beautiful. It was warm.
I wish I could have seen it. That sounds absolutely amazing.
So with the bus died, and I'll save you the gories of that, but eventually what we did was we needed to operate and do our stuff. So we rented a U-Haul every Saturday, renting a U-Haul and doing all of our medical care in the back of a U-Haul. We would have volunteers holding up a sheet so that there was some privacy. And then after about 9 months of that, which was definitely wear on us, we were able to buy an old RV and did a makeover. And so we've been operating out on an old RV, took out the carpet, did all the stuff, and remade it. And just recently, just last week, we retired the RV because finally we are now in the lobby of the health department on Saturday mornings from 9 to 12. This is like pre-Roe versus Wade, taking medicine out of the alleyway, which we were in a cul-de-sac, there's no one else there, out of the alleyway and into mainstream medicine. And the really neat thing is that it gives two messages. One to the community, that these are our people. We need to take care of them. We can't just shine them on and have their connection take care of them. And the other message is to our patients. Walking into the health department, seeing a big sign saying public health, and seeing that we offer, besides clean needles, medical care, and also substance use disorder care. People can get started. We write the prescription for them for buprenorphine right then and there. And we're starting to have more and more of a flow of people doing that. It's not a rare occurrence. It's about half of the people coming for medical care, half of them are for substance use disorder.
Marc, your passion is absolutely contagious. I mean, you could see how much blood, sweat, tears, and love you have for your community and how much work you've put into keeping your community safe and alive. And my hat's off to you. You have nothing but my utmost respect. You are an amazing human being doing amazing work out there.
Thank you.
Marc, I hear you have a letter from a colleague that you would like to share. Can you go ahead and share that letter with us?
Okay. This is one of our counselors who understands trauma all too well. He was, if any of you remember the Chowchilla kidnapping of the school bus and the children, he was one of those children. So he understands trauma. I titled it Epistle of Larry the Counselor and just copied it. Here it goes. First and foremost, without fail, without having met every participant engaging in our services, there are a few things which I know about all of them. I know they have hope for their future. They believe the future is coming, and they all, every one of them, want to meet that future. I know they are courageous. In recovery, we often say the scariest walk is the one across the parking lot. This walk takes courage. I know they are strong, but whatever means we have chosen to muddle through life, the fact is we have gotten this far and not given up. Some have done very nefarious things to get this far, but here we are and we keep pushing forward. And I know they are tenacious. Yes, they might still be using illicit drugs. Yes, they might be missing dosing days and counseling sessions. Yes, they might be argumentative, shady, shy, untrusting, and outright hostile on some days. But they keep coming back. They do not give up. They have not thrown in the towel. For these reasons, the men and women of the clinic have earned my respect, my time, my loyalty, and my 100% of who I am for their betterment. I choose not to judge, condemn, or even give my opinion of higher and better expectations. I choose to exhort, lift, encourage, lead, guide, and sometimes even call out the bullshit I see in a positive way. Every day I'm excited to go to work because I'm going to talk to some of the finest people who I've ever had the pleasure of meeting. Not because of where they are in life, because of where they see themselves going in life. A person cannot have an inkling of an idea of what it is like removing an elephant from your chest until you've tried to lift one off. My participants are doing their heavy lifting. Every one of my participants is working on their 5-year plan. 90% of them didn't even know planning 5 years in the future was possible until we started talking about their dreams, their aspirations, their want from life they are living. I have a few who are enrolled back in college to finish degrees that they walked away from years ago. I have some who have re-entered the workforce as they have found their purpose and their path. I have some who have started their own business plans and have started working towards becoming their own bosses. I have lost count of how many of my participants who have tested dirty when I've met them and are now testing clean, except for their medications. All of these people want to say thank you to me. I tell all of them to go and look in the mirror and say, thank you to that person. I am just a guide. They are doing the work. You might think I'm bragging about myself here, but this cannot be farther from the truth. My participants do all the work. All I have done is remind them that they are worth the effort. After a lifetime of being marginalized and ostracized, after being judged and condemned, these men and women have forgotten their worth, both within themselves and the worth they bring to the world around them. I am a simple reminder, and trust and believe I am not the only counselor in our clinic who's helping their participants achieve their goals. All of the counselors have participants giving clean tests, looking towards their future, going back to work and school, and finding pathways through their suffering and into the abundant life that they have been promised. For some, it takes a little longer than others, but it's the participants that they don't give up. Neither will we. That's our promise. There definitely are some clinics whose only purpose is to hand out doses, but even those clinics offer the same chance for harm reduction we at our clinic offer. In an era where cities and states are out on the streets handing out user kits and in some cases illicit drugs to the human suffering addiction, we at our specific methadone clinic are handing out medication, counseling, and futures to those who are willing to believe there is hope beyond pain. This is from the counsel, Larry Park, and he has permission for it to be read.
Thank you. That was quite powerful. I love that closing statement. There is hope beyond pain. Thank you for sharing that. What closing thoughts do you have for primary care docs out there that are motivated after hearing you speak, but just need a little push to get that prescription written?
I'll tell you the same thing I tell the residents that I train. We've been pushing each of the residency programs in the local area to train our residents in addiction medicine. And the thing I tell the residents is, you become comfortable and get the ability to prescribe buprenorphine for opiate use disorder. You'll be a jewel in any community that you practice in, that any person coming in and say, hey, doc, I got a problem. I have an opiate problem. I've even gone on to using heroin or fentanyl. You could look that person in the eye and say, I can help you.
Wonderful. That's great. Thank you. Dr. Lasher, you've presented a compelling case for how harm reduction isn't just an alternative approach, but a vital tool in our family physician toolbox. Harm reduction offers a humane and effective alternative, but it really does require us to challenge deep-seated stigma and outdated policies. Your expertise has shown us that harm reduction is not about enabling addiction, but about meeting people where they are and providing them with the tools and support they need to stay safe and progress towards healthier lives. Let's champion this paradigm shift and advocate for policies that prioritize harm reduction, not punishment, so we can truly address the complexities of addiction. Remember, addiction medicine is just good family medicine. Thank you.
If you're looking for the full text of the Epistle of Larry the Counselor or other resources on MOUD or substance use disorders, check the show notes at familydocs.org/podcast or visit CAFP's substance use disorder webpage at familydocs.org/SUD. If you're looking for a family medicine peer to walk with you as you begin to incorporate MOUD, you can link to our MOUD champions on that same page, familydocs.org/SUD. This podcast was created, produced, and recorded by the California Academy of Family Physicians. The Family Docs podcast series 1 in 5, Increasing the Odds for OUD Patients, is supported by the California Department of Healthcare Services. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent or the California Academy of Family Physicians.